Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 563 of our pharmacotherapy series, which majors in sleep disorders. PCB asks whether he can try triazolam for the treatment of his sleep disturbances. What would you recommend? PCB should be informed about the likely causes of his sleep disturbances, i.e., time zone shift, caffeine-containing beverages, pseudoephedrine, new surroundings. He also should understand that it may take 1 to 3 weeks for his system to readjust after traveling. The importance of non-pharmacologic interventions, particularly those that pertain to re-establishing a desired sleep-wake cycle and sleep hygiene education, to improve sleep, should be emphasized. In addition, an hour of bright light in the morning can serve as an environmental stimulus, normalizing the circadian rhythm. If PCB's sleep disturbances persist despite adhering to cognitive behavioral interventions, a prescription hypnotic may be necessary. Short-acting hypnotics like triazolam are effective to induce and regulate sleep if the stay will be relatively short, that is less than 5 days, and if critical activities must be accomplished during the first 48 hours after arrival at the destination. Triazolam, indicated for difficulties with sleep latency, has a rapid onset of sedative hypnotic activity, that is within 15 to 30 minutes. Triazolam also has a short half-life of approximately 1.5 hours that does not contribute to next-day impairment at recommended doses, that is 0.125 to 0.25 mg for healthy adults, 0.25 mg for elderly. Women may be more susceptible to the adverse effects of hypnotics than men, possibly due to greater oral bioavailability. PCB could ask his physician to prescribe triazolam 0.125 mg, as needed. Disadvantages of benzodiazepines, and triazolam in particular, include the impairment in new learning or anterograde amnesia and the potential for complex sleep behaviors, e.g., eating, sleeping, driving, or other activities while being asleep. These effects can interfere with daytime functioning and result in the inability to remember new information learned on the trip. PCB should be cautioned regarding tolerance to the hypnosedative effects and physiologic dependence that can occur with long-term use of a benzodiazepine and the potential for rebound insomnia with abrupt discontinuation. Of the benzodiazepine receptor-active hypnotics, triazolam is most commonly associated with rebound insomnia, i.e., daytime nervousness, jitteriness, and insomnia worse than before, if abruptly stopped after more than 7 to 10 days of continuous use, and withdrawal problems, likely related to its high binding affinity at different gamma-aminobutyric acid, abbreviated as GABA, receptor subtypes. The pharmacologic properties of benzodiazepines, including sedation, anterograde amnesia, anti-anxiety and anticonvulsant activity, muscle relaxation, and ethanol potentiation, occur as a result of interaction with various GABA receptor subunits. The sedative effects of benzodiazepines are primarily mediated via activity at the alpha-1 subunit of the GABA-A receptor. Non-benzodiazepine hypnotics, abbreviated as NBRA, also known as Z-hypnotics, such as zaleplon, zolpidem, and S-sopaglone, have fewer reports of rebound insomnia and anterograde amnesia at recommended doses due to selectivity for the alpha-1 receptor subunit, and also lack significant anxiolytic and muscle relaxant effects compared with triazolam. Also, triazolam's short half-life and rapid decrease in blood levels create the potential for withdrawal symptoms including anxiety and insomnia. Triazolam is highly effective in inducing sleep when used on an as-needed basis. Long-acting hypnotics, such as flurazepam, may prevent the traveler from awakening in the morning and should be avoided. PCB would like to try melatonin for improved sleep, but wonders whether it is safe and effective. So my next question to you reads: what information is available on the safety and efficacy of melatonin for circadian rhythm or other types of sleep disorders? Melatonin is a naturally occurring hormone secreted by the pineal gland, located in the center of the brain. The pineal gland is connected to the retina via a nerve pathway that runs through the suprachiasmatic nucleus of the hypothalamus, the body's circadian clock. The pineal gland produces melatonin, a byproduct of serotonin metabolism, only during the nocturnal phase of the circadian cycle and only in the presence of relative darkness. Studies in adults show that melatonin has at least mild sleep-promoting properties when administered before the period of natural increase in endogenous melatonin, around 10 p.m. to midnight. It causes significantly more sleepiness when taken at 8 p.m. compared with 11:30 p.m., theoretically because the brain's receptors are already saturated with melatonin late at night. Doses between 0.5 and 5 mg taken close to the target bedtime in the new time zone can decrease sleep disturbances. A systematic review of 10 clinical trials showed melatonin was more effective for travel eastward crossing multiple time zones. Melatonin 0.5 to 10 mg has been found effective for entraining the circadian rhythms in blind people, alleviating insomnia in developmentally disabled, handicapped, or autistic spectrum children and adults, and treating short-term, initial insomnia in children with attention deficit hyperactivity disorder. The safety and effectiveness of melatonin for long-term use or other sleep disorders has not been established. Consumers selecting melatonin products over the counter should be advised the purity of melatonin is not regulated by the FDA. Although doses of 0.5 to 5 mg melatonin are well tolerated, side effects include sleepiness, headache, and nausea. Melatonin use has been associated with reports of depression, liver disease and vasoconstrictive, immunologic, and contraceptive effects. PCB's doctor gave him a prescription for Rameltian 8 mg at bedtime. How does Rameltian compare with melatonin? Ramelteon is a highly selective melatonin agonist at melatonin 1 and 2 receptors, abbreviated as MT1 and MT2. MT1 regulates sleepiness and MT2 adjusts circadian rhythms and regulates phase shifts from day to night. Ramelteon is approved by the FDA for insomnia characterized by difficulty falling asleep. Clinical studies in primary insomnia show it decreases the time to fall asleep by 10 to 19 minutes, and it increases total sleep time by 8 to 22 minutes. One controlled trial showed it was superior to placebo in decreasing time to fall asleep during a 6-month period, although Ramelteon's onset was 15 minutes faster than placebo after week 1, but only 9 minutes faster at 6 months. Its half-life ranges from 1 to 2.6 hours. The half-life of its active metabolite, M2, is 2 to 5 hours. Ramelteon undergoes hepatic metabolism by cytochrome P450 isoenzyme CYP1A2. Increases in serum concentration occur even with mild liver disease, so caution is recommended for patients who have at least moderate liver disease. Fluvoxamine is a strong inhibitor of CYP1A2 and given with Ramelteon dramatically increases its serum concentration. Co-administration with fluvoxamine or any potent CYP1A2 inhibitors should be avoided. The most common adverse events observed with Ramelteon include headache, that is 7%, dizziness, that is 5%, somnolence, that is 5%, fatigue, that is 4%, and nausea, that is 3%. In clinical trials, no evidence of cognitive impairment, rebound insomnia, withdrawal effects, or abuse potential was demonstrated even at doses up to 20 times the usual treatment dose. These results were markedly different than the abuse potential and side effects of triazolam at treatment doses and doses up to 3 times higher than usual. Of note, no study has directly compared Ramelteon and another hypnotic for insomnia management. Ramelteon is a reasonable option for patients with initial insomnia with no abuse potential and little to no risk of next-day impairment. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arora, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 564.